Hello, everybody, and welcome to the IOCDF Research Roundtable, the IOCDF live stream where we pick an interesting topic within the OCD literature and discuss it with the folks who know it best. My name is Kyle King. I'm a current first-year medical student at the Yale Medical School. I'm interested in psychiatry, particularly OCD, but more importantly than that, I'm someone who lives with OCD, so a lot of the things that we talk about on this stream are super relevant to me and super interesting to my life and my family's life. As always, I'm joined by my co-host, Jon Abramowitz. Jon, if you'd like to say a word about yourself.
Absolutely. Thanks, Kyle. Always good to be here each month. I'm Jon Abramowitz. I'm a professor at the University of North Carolina at Chapel Hill. I'm a clinical psychologist and also fascinated by OCD and have been studying it pretty much since my career got started in the mid-1990s. And it's always fun to be here and talking about one of my favorite topics.
Yeah, and as some people may be aware, first I should say that we have an illustrious panel and a much larger panel than we typically do today. And I'm super excited to get started with this conversation and introduce all our panelists. But just kind of like a topic overview, I suppose. As some of you may know, next week is OCD Awareness Week. It's the time where we kind of, as a community, try to spread the word about what living with OCD is like, what real OCD really is. And really try to provide as much support as we can to folks living with OCD. And in honor of OCD Awareness Week coming up today, we wanted to talk about perceptions of OCD and stigma of OCD and just kind of like general awareness of OCD from a research perspective. And I was kind of thinking through what questions I wanted to ask our panelists today, and I was reflecting on my experience in like medical institutions, I suppose, now that I'm in medical school. And it's really shocking to me still how important it is that we keep talking about OCD awareness and keep trying to spread the word about what real OCD really is. Just the other week, I was talking to some kids at dinner, and they're kind of my close friends in the medical school, and I disclosed to them that I had OCD. And we started talking about OCD, and one of them said, "Oh, that's that thing where like, you want to make sure your hair dryer's off, right?" And I said, "Well, yeah, that can be a symptom someone may have." And they were like, "Oh, well, I never understood why if someone just wants their hair dryer to be off, why don't they just take their hair dryer with them in their car? Like, why don't they just take it with them everywhere?" And kind of all these medical students at this table I was sitting with agreed that that was the ideal treatment. That was the best way to go about addressing OCD. And I was just shocked that like these were future doctors who just completely didn't understand what OCD was and how to treat OCD and what it meant to affirm one of these irrational thoughts and what it meant to fight against one of these irrational thoughts. So that's the long way of saying that this topic is still super important to talk about. Okay, I'll get off my soapbox. Actually, wait, no, I'm going to stay on my soapbox for a little while longer because I have some announcements to make before I introduce our panelists. First, this live stream is educational and is not intended to replace therapy. For treatment-related questions, please work with your provider or contact a local clinician. You can use the IOCDF's online resource directory at iocdf.org/find-help to locate a trained clinician near you. Also, the IOCDF is not a crisis hotline. If you're in a crisis or if you're ever feeling suicidal or unsafe, please go to your local emergency room or call 911 or the suicide prevention hotline at 800-273-8255. I also want to note that there's a comment section. We love when you put comments in the comment section. We love when you kind of join in with our discussion or ask us questions, and I'll try to get to as many as I can throughout the stream. We just want you to know that everything that you put in the comment section will live online forever. So just be respectful of what you say, although we've never had any particular problems. Also, kind of in line with this idea of spreading the word about OCD, we're excited to share that the IOCDF has officially kicked off fundraising for our research grant program as part of our 30th anniversary celebration. This year, we're aiming to fund more research grants than ever before, supporting groundbreaking studies that deepen our understanding of the causes and treatment of OCD and related disorders. Your contribution will help us close the gap in the funding disparity and launch careers of promising young investigators, one of whom I know we have on the stream today, Best of all, 100% of your gift will go directly to supporting research grant awards that make a direct impact. Thank you for your support. Please visit ircdf.com/donate research to learn more and donate what you can. We'd really appreciate it. Research is kind of the backbone of spreading awareness and making sure that people like future medical students actually know what OCD is. Okay, that's enough yapping for me. Time to turn to our guests. The first guest I have on the sheet of people to introduce is Lorena Fernandez de la Cruz. Lorena is, I think I did all right.
Yeah, you did amazing. Yeah.
All right, good. I need that validation. Lorena is an assistant professor in the Department of Clinical Neuroscience at the Karolinska Institute in Stockholm, Sweden. She is a clinical psychologist trained in Spain, the UK, and Sweden, and has worked as a clinical researcher for the past 15 years. Her current research mainly focuses on the health consequences of OCD and improving the lifestyle habits of folks with OCD. She also works in the development and dissemination of evidence-based treatments for OCD and related conditions in children and adolescents. Lorena, Boris warned you that I ask weird icebreaker questions. So this is the one that I dreamed up before coming here, sitting on the stream. It's not that weird. I was gonna change it for each person, so no one you're not subjected to the worst of it. If you had to sit down for a 30-minute Q&A session and you got to ask anyone across the table from you any sorts of questions you want, who would you want to be sitting across from? Dead or alive?
What kind of questions did you say? Sorry, you said that again?
Just like you get to get a meal with anyone. Who would it be, dead or alive?
Oh, this is a very difficult question. So because I am in Sweden, as you know. Today they gave away the Nobel Prize to Han Kang, who is a Korean author, I believe. So I think I would like to sit with her and talk about her books. Does that work? Because this is a very this happened today. So I think I would like to talk to her and see how she feels about her winning the Literature Nobel Prize. So yeah, I think her.
All right. Yeah.
They do that at Karolinska, right?
Here at Karolinska they do the medicine. It happened like a few days ago. But the literature is done in Sweden, but not here at the university. But it's also ours. I feel like it's also like a Swedish based thing.
Okay, I've been to the room where they do, I guess, the medicine.
Yeah.
Where they give that out, and I told. This was a long time ago when I visited Karolinska, and I told the people who were taking me there, this is probably the only time I would ever be in this room.
Yeah, it's quite exciting, and then they have like the lecture, and it's quite nice. There's like a very long queue every year. So yeah,
that's cool.
To be fair, John, I feel like you're in pretty good company amongst people who haven't won the Nobel Prize. Yeah. The other guest, or the second guest I'd like to introduce, is Dr. Amita Jassi. Amita Jassi is a consultant clinical psychologist at the National and Specialist OCD, BDD, and Related Disorder Services for children and young people in the UK. She has worked with this client group since 2006. Amita is the lead of the BDD branch of the services, as well as the research lead for the clinic. Amita is taught and trained nationally and internationally on child and adolescent OCD and BDD. She is the author of several books and has over 40 publications in peer-reviewed journals on OCD and BDD, and engages in media work to increase awareness and understanding of these conditions. Awareness is the word of the day. Amita, I'm going to ask you a similar but slightly different question.
My anxiety. Do you want to take the anticipation? But okay, bring it on.
Who would you like to sit at a meal with? But it has to be an athlete.
Oh my goodness. Oh, actually, Muhammad Ali. I would be really, yeah. I used to, as Lorena knows, so Lorena and I have crossed paths. Well, we still work together and collaborate. I used to box in theory.
In theory, what does that mean?
I used to go, but wasn't great at it. And I just then got really interested in his life, and I just think he's inspirational. So yeah, that's who I would like to sit across the table with.
Good choice.
Yeah, no, gotta agree. He's inspirational, and I would love to see you theoretically box.
What, with him? Oh.
No, just anybody.
Just generally.
Yeah, I like to think that I theoretically have run the Ironman, but mostly in theory. Our third guest is Dr. Elyse Stewart. Elyse is a clinical psychologist. Elyse, right? Is a licensed clinical psychologist at the New England Center for OCD and Anxiety, or NACOA. She received her doctoral degree in clinical psychology from SUNY Binghamton, where she focused her studies on factors that may affect treatment outcomes and accessibility for those with anxiety disorders and OCD. Elyse is interested in the dissemination of evidence-based treatment, particularly working to refine the optimal delivery of exposure-based practice. She's dedicated to training clinicians in the approach and currently teaches at NACOA's Exposure and Response Prevention Foundation courses. Additionally, Elyse maintains a leadership role in NACOA's intensive outpatient program, where she continues to contribute to the training and supervising of clinicians in the delivery of exposure therapy within that program. Elyse, same question, different twist. This time you have to pick an artist.
Oh, amazing. I was actually hoping you were going to pick an artist. Okay. I would pick Vincent van Gogh.
Okay, why?
I just think his paintings are incredible. Those like immersive things that they have that come to the different cities. Yeah. So I went to that immersive one and oh my gosh, mind blowing. It was just so incredible, so beautiful. So be able to talk to him, that would just be so cool.
Okay. I gotta check that out.
I got lucky with that question. So thank you.
Dang it. My whole goal is to try to throw you guys off.
Well, you have an artist here. I'm an artist too. So
I didn't know that. Whatever. I'll get you next time. Our final guest today is Uma Chatterjee. Uma is an award-winning neuroscientist, science communicator, and mental health advocate. She earned her MS in neuroscience from the University of Texas at Dallas and is currently a neuroscience PhD student at the University of Wisconsin-Madison, where she researches the neurobiology of OCD and novel pharmacology treatment targets. Uma's neurobiology research and advocacy are all informed by her lived experience with severe mental illnesses, including OCD, young adult cancer, chronic illness disabilities, and her identities as a non-traditional student and a second-generation South Asian immigrant. Her survivorship serves as the bedrock of her advocacy, carried out through her work as a globally invited public speaker, science communicator, bridging the gap between research and lived experience, and host of the podcast To Chat with Uma. Uma's also a dear friend, so I don't want to confuse her too much with my questions. Uma, if you had to sit across the table from anyone, who would it be? But you have to pick an actor or actress.
Oh, this is so hard. I don't know anything.
Anyone.
Actor, actress.
Anthony Hopkins was thrown out in the chat earlier, which is taken by surprise.
Actually, Amanda Seyfried, and not to, it happens to be related to this. I've been hearing a lot about her story with OCD, and she advocates really, really well. I had no idea, so love to talk to her.
Yeah, love that pick. And a good segue. I have a tradition of starting every roundtable with an annoyingly vague and broad question. So I wanted to continue that tradition today and start with kind of focusing on the perception part of the title. The title of today's talk is Perception, or I think it's awareness, perception, and stigma. I want to start by talking about perception. So we have a pretty diverse groups of folks here in a lot of different parts of the world. How is OCD perceived by the public where you guys all are, and in the communities that you circle? And do you think that it's fairly perceived in the communities you run in? And that's kind of open to anyone.
I'm happy to kick off, and Lorena might want to contribute to this because you've had some time in London. We've done some research, haven't we, around this? I think it's what you were saying earlier, Carl, about quite stereotyped perceptions of OCD. So in the UK media, there's quite an interest and programs on the more classic, cleaning, compulsions and OCD. And in fact, that we have a program here called Obsessive Cleaners. I mean, it's kind of that level. Wow. So I think when people think about OCD, it's kind of, that entertainment and just these views. So I think, we know how heterogeneous it is, how diverse it is. So I think there is a kind of perception of it being just one particular type of OCD. And when I talk to people about the different types, they're quite struck by that. And I know we'll come on to this later, and I won't say much now, but Lorena and I have done series of studies, and we're really interested because it's a very culturally and ethnically diverse area, particularly where we're situated in South London. And we've done some research on some of kind of how diversity around ethnicity comes into that, and perceptions, not just around OCD, but health seeking and so forth. So yeah, I would say people know what OCD, like if you said OCD, I think people know what it is, but have a particular view of what OCD is, like it's all washing and cleaning, but there is kind of a range of views across cultures and ethnicities and so forth.
Yeah, and is that... You got
so here I am. I'm in the New England area, and I did in grad school. I was in upstate New York. We did some preliminary kind of research of what do people think OCD is. So we just asked people, what is OCD? And the top answers, at least for New York State, that we got were in saying basically compulsion, so repetitive behaviors. The second answer was, I don't know. And then the third answer is perfectionism. So generally people say that they recognize what OCD is. They've heard of the term before, but when you ask, what does that mean? It's those three things, compulsions, I don't know, or perfectionism. And I know we'll probably get into this a little bit later, but just thinking about in terms of what this means for treatment, treatment seeking, treatment accessibility. OCD is so much more than, those things. It can present in so many different ways. So just recognizing what OCD is and then actually getting the appropriate treatment, so important. So I can speak for kind of the New York State area of kind of the general perceptions. And that's what we found.
In a university setting, we happen to be in the southeast of the United States, but just in the university setting, Elyse, similarly to what you're saying, I think a lot of people think that OCD is perfectionism, which is a big thing, and in schools and UNC is it's a highly academically strong, competitive university. So you have a lot of people that try to be perfect, and I think another thing that we see at our clinic is we often see folks who present saying that they have OCD, but then they've got maybe something else that is like an OCD related disorder, but isn't technically OCD, hair pulling, skin picking, hoarding, things like that. Not so much hoarding actually, but there's a lot of mistakes around what is and what isn't OCD.
Yeah. Yeah, it's interesting that, like, I guess the public perception of OCD seems like a collapsed version of what OCD really is. It kind of narrowly takes it down to one symptom. Uma, I'm curious, like in situations where you've shared your OCD with others, kind of what have you had any like reactions that have stood out?
I'm going to try not to make this a soapbox, but Kyle, you started it with your share earlier. It just makes me so angry, and I'm trying to channel that into making a difference. But as someone who discloses and talks about my own OCD, and then now as a researcher and a trainee and someone who researches OCD, I mean, what else do I do with my life at this point? I am constantly, I'm sharing my findings, I'm sharing my work, and I'm sharing it in the context of my lived experience to put a face to the name. At this point, I was trying to count for the purposes of sharing this point. I think I've presented at like 40 conferences. I'm talking about it all the time. I just got an NIH fellowship. I had to talk about it there. And I kid you not, every single time, this is in research settings alone, let alone the rest of the world, I will always get a comment or a question or something like, oh, well, you must be so good at your work because you have OCD, or, oh my gosh, I'm so OCD too. Or some of the worst parts are, why do you even study it? Like, you could be doing something so much better with your time, because like OCD is not a big deal. It doesn't even matter. So there's the element of it being reduced to all of your points to a very specific set of symptoms and not recognizing the debilitation. But then there's, even worse when it's not even seen as a disorder and it's straight up just seen as something that's a personality trait or a quirk or an adjective, and the things that I'm very tapped into on a, human level of talking about it and always getting the comments back. It's just so frustrating. And I think it's even worse when it's amongst people who are mental health professionals, who are psychiatrists. I mean, who I'm presenting to at conferences most of the time are psychiatrists, researchers, neurobiologists, public health professionals. And almost nobody knows what the disorder is or why it matters. And that, obviously, we're going to talk about the downstream effects of that, but it's really frustrating, especially Kyle, like just relating to your experience of, as a person who understands how horrible it is, it's really personally painful to hear that. And then also to put that aside and try to say it as, rationally and logically and even keeled as possible while, still maintaining the human element of it. So yeah, it's really bad.
Yeah.
And Uma, you said oh, sorry, I've just jumped in, but I think there was something you just said there, something that presses my buttons when people say, oh, I'm a little bit OCD. And you're like, it's not, when you add in the D to it, so there was just something you said in that. That's a real bugbear. Like I know. And I have to really okay, here we go. But yeah.
I mean, oh, you go.
No, I was going to say, I get that some symptoms are more known than others. And it's also true that I guess that we will talk about stigma later, but also some symptoms or some symptom dimensions are more stigmatized than others. And sometimes people may feel more comfortable talking about contamination fears or washing or symmetry because it's like, oh, I also have a little bit of this and I also have a little bit of that. And it's more, people understand it in a better way. But if you have at some point to disclose aggressive thoughts or sexual obsessions, that is something that people do not talk about. And because it's not talked about, then it's also less known by the general community. And also now I was very happy that you brought up this example with your medical student colleagues, because sometimes I have the feeling that it is a bit of a lottery if you go to your general practitioner, that they may or may not have someone in their family that has OCD, and then they may know more about the symptoms. But if that is not the case, then they may know the basics, and then it is a bit more difficult to explore whether this is something that deserves a referral to a more specialist service, or whether this deserves like this treatment or this other treatment. So yeah, I think that we have a lot to do when it comes to education, not only the community, but also the medical community as a whole as well.
Yeah, you're defining two levels of, on the patient level, the client level of recognizing, oh, I'm having these intrusive thoughts, I'm having this experience, this is something I should get help with, right? And if the client themselves don't recognize it as OCD, they may go see a professional, and then it's on the professional to recognize that it's OCD. And if the professional doesn't recognize that it's OCD, then it could take, a really long time to actually get the appropriate treatment. Which is really sad and really, really unacceptable. We're finding that there's rates, I think it's 7.5 years to get the appropriate treatment. And it's so sad because we have treatments that work, exposure works. So especially, you're making a comment about some of the more taboo symptoms of OCD. My goodness, thinking you're the only one of having these harm obsessions, these, other horrific obsessions, to then disclose that to a practitioner, and then what the practitioner does with that information can be really, really scary.
We see this exact thing, Elyse, come up. We're doing research on perinatal postpartum OCD, and we see this to an alarming extent in women, and actually sometimes dads too, who present and they say, I have these. Actually, many of them are afraid to even talk about their symptoms for the reason that they're talking about. But they say to their physician, their OB or whoever it is, I have these thoughts about what if I harm the baby, stuff like that. And they don't know what to do. The professionals don't know what to do. They think the person has schizophrenia, which of course they don't. They don't understand what OCD is. And a lot of people are, because of the stigma, they're afraid to even bring that up because they're afraid they're going to be, locked away or something like that.
I'm curious, you guys are all in universities or were in universities for a while. How is OCD taught in psychology programs, or is it addressed? Clearly something's going wrong where medical professionals and clinical psychologists, or I don't mean to lump clinical psychologists, but people don't know about this. Professionals don't know about OCD like they should. So yeah, how was it discussed when you guys were in training, and what are problems you guys see?
Carl, you're now asking, like, this is going back quite some time for me personally. Like, I was like, when did I do my training? And then I specialised quite quickly. I think, and I guess the systems probably are different, aren't they, sort of across the world. So when I went on to my doctoral training for clinical psychology, I think we got like 2 hours on OCD, but I can't remember sort of my undergraduate as we have here. Probably just a quick mention in terms of like mental health conditions. So I would say that's probably as much as we get, bearing in mind the sort of training we have for clinical psychology here is 3 years, and you're learning about sort of mental health. And in fact, we've been doing lots of work across the courses saying you need to do more than that. So yeah, very little, I would say. So that's the UK.
Yeah, I would say in the US, it's really diverse. It depends on the program that you're in. The program that I was in, my interest is in OCD and anxiety disorders. So I sought a program that had really, really excellent training in that, right? So it just kind of depends on the priorities of the program. So I can't really speak to others. But I do know, just thinking about dissemination efforts, right? We can fall into this kind of ivory tower situation of we have really good research studies, we create awesome treatments, and then we need to figure out better ways to disseminate these treatments to the public.
Yeah.
In my experience, I did my undergrad in psychology, my master's in neuroscience, I pivoted, and then I'm doing my PhD in neuroscience. And in all 3 levels of training so far, if it's mentioned at all, it's mentioned incorrectly. And I'm the annoying person that, of course, is going to correct people out loud. And if it's not mentioned, typically, especially in my neurobiology classes, especially in systems neuroscience, where they're giving examples of different disorders that are impacted by certain circuits or certain systems, of course, OCD is never mentioned. And then I'm the annoying person that's going to raise my hand and say, oh, the dopamine system or the D1, D2 pathways, that's also implicated in this disorder. And I see the look of confusion when on people's faces, like, why would you bring up this cleaning thing? And I've even heard that sometimes. I've also heard professors talk, make jokes about, oh, these people might just be so OCD, talking about, some sort of phenomenon or some sort of thing. So, and I've gone to universities that are, R1 research institutions that have lots of funding for psychiatric disorders, hence why I chose them. And it's just the one disorder that tends to be overlooked. And of course, I can't generalize to everyone, but that's, in talking to many trainees who are in my position, very, very common, to the point where I've taught myself most things I know about the disorder. And then I go to conferences like the IOCDF and kind of, learn from all the experts talking, and then go teach my professors and my peers.
Carl, when you asked that question, I know you were focusing more on sort of us as mental health professionals, or have done that kind of training. I sort of think about it more broadly, and some of the work we've been doing sort of in our clinic, because I do research, but actually first and foremost I'm a clinician, is around sort of looking at and I work with young people, so we're thinking about where do young people go. So we've talked about the general practitioners, you mentioned that, Lorena, that's kind of been one level of increase in awareness and thinking about what they know, but we've done work in schools as well, because most, that's where, hopefully, if OCD is not getting in the way too much, that's where young people are spending time thinking about what signs can teachers look for. And then of course GPs, general practitioners, mental health. So we're trying in this clinic sort of with looking at the, what is the awareness, what do people know, and then trying to tailor interventions and target like a multiple approach, because I think it's those broader societal views, isn't it? And I think we've talked about sort of our experience of how people in the general public talk about OCD, but also then targeting where are people present, like, so it's a bit more of a shared approach, because not everybody will do the mental health sort of training and things.
No, certainly. I asked a more narrow question, but it's clearly something that's it's a thing that needs to be solved and considered very seriously, like across all dimensions of society. I kind of want to pick up on a point that Elyse mentioned, just kind of like thinking about, I guess, the downstream consequences of this perception of OCD as just one sort of symptom, or maybe ignoring the more taboo sorts of symptoms. How does, and what does the research show about how these perceptions of OCD affect help-seeking behaviors?
Yeah, I mean, to me, that's the key point of everything that we are talking about today, like perceptions, awareness, stigma, how this actually affects the delay in treatment seeking. So now Elyse was saying there's like a 7-year gap between all the studies say up to 9 years from the time that the symptoms start being impairing to the time that you actually get the correct diagnosis and then you get the correct treatment. So during those years that you're not getting the correct treatment or you don't have the correct label, then how is your life being affected when it comes to how you perform in school, how you perform at work? And here we have also conducted some studies about that and how people with OCD have more issues when it comes to schools and getting a university degree and how that affects your how you can work and if you are unemployed and how that affects your family. And as Amita is saying, this is so very many fronts that we have open. So you can start in schools, you can start with the medical community, you can start with the community of people that suffer from these symptoms, the general public that may not suffer from these symptoms, but can also help identifying things or at least not make fun of it. Or as Uma was saying, like treat these symptoms as a condition that actually affects your life and it's nothing to be laughing at. So I think that there's so many fronts open. But I think that in a way or another, here from the OCD Foundation, your guys like doing excellent work. And from the research point of view, there are also initiatives that are working on the same direction. Yeah, we are also working not for OCD, but we're working on an educational program for clinicians about body dysmorphic disorder, which is a disorder from the spectrum that is even less known than OCD for, again, general practitioners. I think that mental health professionals have it easier because, it's in your mental map. But for doctors, in their defense, we have to say that there's a lot of things to think about when you have a patient in front of you. But I think that, for example, with postpartum depression, so now everyone knows what postpartum depression is. And I think this has been a change in the past 15 years. And now general practitioners know that they have to screen for this because this is something that happens often. So if at some point if you reach this stage where people know what OCD is, and then we can screen about OCD, I think that would be very important.
Yeah, it's a good point about physicians being overwhelmed, but what's a shame is that they view mental health conditions as being not worthy, less worthy of assessing and all that. We developed a 4-item scale to assess perinatal OCD. 4 items, 4 questions. And we still got a lot of pushback when we tried to get this into, assessment questionnaires. You go to the doctor and you fill this out, when you're sitting in the waiting room. 4 lousy questions. And we got lots of pushback. Oh, they're never going to want to do this. We already give enough questions. We have to change.
Yeah.
It's so hard because how do we make this a priority, right? Like OCD is one of the leading causes of disability worldwide. So how do this is kind of the red tape of the barriers, right? So we have an assessment that we know that we can use to catch this. And then how do we actually get people on board, the people who need to get on board, get them on board to actually start implementing it? Easier said than done, of course.
I mean, you pose this question as more of a rhetorical question in terms of like, how do we get them to care? And I think to me, the answer is by people sharing their stories and people talking about how debilitating this disorder is. And I know even just from me opening my mouth and sharing my story, and, as someone who's here today as a researcher, like part of my story is that I was misdiagnosed and mistreated for 25 years. I was housebound. I attempted my life numerous times. I had failed out of college. I was in a religious cult. Like my life looked completely different than it does today. And the power of accurate treatment and not having the typical stereotypical presentation of OCD, even just sharing that version of a story to professionals who didn't care before, I know it's made a difference in people having that on their radar, mental health professionals who don't treat OCD, who will at least refer out to people now. It's just people like us, people like me, Kyle, people like you guys talking about, your patients, obviously anonymously, but like the general story. And as much as we focus so much on our work, it's about making it public and getting in front of people's faces and showing them what this disorder truly is. So we can all do it.
Mm-hmm. I think what you said there, Uma, just about like, what is the point of recognizing it? And it's because and I think Elyse, you said this as well about the treatment outcomes and sort of sharing that sort of accurate diagnosis can lead to access to, treatment outcomes. And Lorena and I did some work because we've done some work around some of the perceptions of OCD across ethnic minorities and different kind of groups. And there's a difference. There were some commonalities, weren't there, Lorena? So we've done a series of studies. I guess this all started from us just noticing in our clinic the disparity between what we were seeing when we stepped out of the clinic in terms of the diversity, but who was stepping in the clinic. So predominantly white British young people and families, and what was going on there. So we've done a series of studies, but what we ended up doing, and Lorena will share, I'm sure, some lovely stories of going into barber shops and doing surveys and so forth. Yeah. We were out in the community, but I think there were barriers that were broad across, that broke across the kind of different ethnicities and so forth. So some of the shame and so forth, but it was more pronounced, wasn't it, in sort of ethnic minority groups. There was a real fear of discrimination and kind of what mental health services can feel like. I think particularly where we work, we're in a very diverse area, and how this hospital's kind of seen. I think there was lots of beliefs, and this is where I'm sort of linking in with what you've been saying, Uma, about treatment. So we found that particular groups, ethnic minorities, were seeking alternative approaches to, if it was recognised as OCD, then they were maybe they would tell their community or go to religious leaders. They were sort of doing alternative things. They didn't think, that CBT was, or kind of mental health treatment was necessarily what was going to help, despite actually Lorena and I did a study where we compared treatment outcomes. And Lorena, you led on this. Sorry, I'm just talking about
go for it.
Where we compared, our standardized treatment in the clinic, cognitive behavioral therapy, with or without medications, and there was no difference in outcomes in terms of kind of those that were white British compared to ethnic minorities. So we know once they're in the door and they get the treatment, and of course we adapt it to the individual and so forth, but that's not the issue. It's getting them in the door. But Lorraine, you might know. Yeah, you probably remember more about stuff.
No, I mean, I think that it was very interesting to see how some barriers were common to white British parents and ethnic minority parents. But this that you were mentioning about barriers that were specific or a lot more prominent in ethnic minority groups, that feeling discriminated within the system was one that kind of caught our eye, because and then I think this is very interesting, like how you also need to feel represented within the system, and that's why it is important to have gender varied and ethnically varied professionals that can come talk to you, so that you feel that you're talking to an equal in that sense. So another one that was quite interesting is feeling stigmatized and discriminated by your own community, like saying, oh, now I have OCD and I'm going to this doctor, and feeling discrimination within your own community. So I think that's very tricky if you are a family living in that community. I think it's super important to rely on informal support groups, your church or your spiritual leader or your family, but it's also very important to make sure that you're getting evidence-based treatment, which you may only be able to find in certain places, unfortunately. So I think that you could have both, and it is important to work within those communities to reduce the specific stigma, and not make people feel guilty just because they are going to the doctor. So those are the points that I remember the most.
We are going back a decade, aren't we? Of some fun times. With you walking.
Unfortunately, they still apply, which is really, frustrating. That to see how in other fields or things, we have advanced quite a lot, but these things still apply. So yeah.
I'm curious too, like you guys are talking about kind of differential stigmatization of help-seeking behaviors or of maybe mental health conditions at large in different communities. How does stigma and level of stigma affect treatment outcomes? It sounds like it definitely affects help-seeking.
Well, I mean, the study that Amita was mentioning now, in our case, so I mean, the thing is that these are people that all ended up in the clinic anyway. But when you compare the white British teenagers and children versus the ones from ethnic minorities, then we did not find any differences in treatment outcomes. So if you finally make it into treatment, it doesn't seem to have an effect in how well you respond to treatment. So I think that is an important message, that if you go to the right doctor or the right psychologist, the right therapist, that you still can get better. But then you have to, pass
all those barriers. Yeah.
First. Yeah.
Yeah, they might be a skewed sample because they've got through those barriers, so maybe they don't hold the same views as the kind of wider sort of community. But yeah, that's been our experience.
Would you say like ways to help people get access to treatment, maybe having education more in terms of like spiritual leaders or community leaders, and in that sense where individuals might not be saying to their doctor, like, oh, I'm having intrusive thoughts, but maybe they might say it to a community leader. Thinking about like how we can help people, bridge that gap of actually getting to a provider to get the correct treatment.
That was the next stage of kind of the work that we did. So once we'd identified that, we went and tried to do more like being where people are and getting through those trusted, having had feedback that they would go to their elders, they would go to their spiritual leaders. That's where then we went to try and educate. I have to say it wasn't as easy as we thought it would be. I think there was some communities where you couldn't even get that far, and I think, Lorena, you had that even at the stage of trying to gather information around abuse, and then we were taking it a step further after the series of studies of trying to integrate and be parts of some of those settings where we could then increase awareness via leads and some communities it was hard, and I think some of that trust still, that then we were hitting some of that. But I think we've tried other initiatives that are kind of more universal and broader through schools and so forth. But I agree, Elyse, I think if we can get through, and I think from speaking to colleagues who've done it a lot longer, it takes time to build up those relationships. The trust, we had a few years to try and sort of do that. It's kind of and they've had more success than we have.
I agree with you. I think that this is like it's like a long-term thing, because I think this is not like that. This should not be patronizing, like, oh, you have to go here, you have to do this, you have to do that. But it's about working together and build this relation of trust over the years, where I trust you and you trust me, and then we work to detect these symptoms and see whether anyone in your community needs this kind of mental health support.
So in the Southeast United States, it's often referred to as the Bible Belt. A lot of religious folks live here, and their first move when they have a mental health concern is to go to their religious leaders. And there have been attempts to try to educate folks, and I don't know about if there's research on this, but just from personal experience, it's really hard. So, a lot of folks who are religious, they have a negative perception of psychologists, psychiatrists. They think we're all atheists and stuff like that. And they've got their own often religious explanations for what causes problems like OCD and how to fix it. Oh, we need to pray more, right? Which is maybe one of the person's rituals. And I think that, it can be helpful to go to the people that are practicing, currently as spiritual leaders and religious leaders. But I think getting some curriculum into their training is really important. And I don't think that that's there. There's very little understanding. Religious scrupulosity, a major presentation of OCD. There's very little understanding of how that works, very little education from what I can glean from talking to folks that I know who are in that field. They just don't learn about it. And what they do learn, if we've talked about, is incorrect.
Yeah.
And I'm making broad generalizations. It's not everyone, but a lot.
Yeah. And now that you said, like, you have to pray more, like, I'm thinking, like, that this is part of because illness perception is like a complicated construct that includes many things. And so one is like the identity, like whether you feel that this is an external thing that happened to you, or whether you feel that the disease is you, like you know, like I am OCD, or I have OCD, or this is an external thing, or what causes OCD, if it's your fault, or if this is something that someone sent to you. So all these things affect the way that you think about what's happening to you, and your disorder affects how you cope with it, and how you adhere to a certain treatment, whether you seek treatment or not, and maybe also how you respond to it. So I agree that we need to work on, for people that give you alternative explanations, that it would be important to address these as well.
So, I mean, we're kind of talking about how to change all the problems that we've identified. What are some ways that maybe talking about OCD may be helpful, like framing OCD so that, you know, people who have a stigma going in may be more receptive to learning about treatment and ERP and all these things?
How would, I mean, I do not have OCD myself, and it's very good to hear from people with lived experience, like how would they want their OCD to be phrased, and what they think it is important for you. And I think that this is also a co-development situation, because from me as a researcher, I think that you are a lot more qualified than I am to answer this question. No, seriously, I think that that this is like a collaborative like work we have to do here. Like, how do we present this, and how would you feel comfortable talking about this? Like, if you hear someone talking about your OCD, how would you like this to be phrased?
I have a memorized spiel, or not memorized per se, but at this point it's so automatic because I say it all the time. But I have to start with what it's not. And, you know, because we have the unique burden as people who study and disseminate it, that we are always, it's safe to assume most people don't know what it is and they think it's something else. So it's like, tear down what it's not. Briefly talk about why people think it's that, because people tend to feel defensive when they hear like that they are wrong about something and it's not their fault. It's because it's conditioned by, you know, our systems, our media, our colloquial language. I mean, I used OCD wrong until I was diagnosed too. So anyway, it's about what it's not, why people think it's that, what it actually is. And I think a really powerful conduit I found in talking to, you know, everyone from researchers to clinicians to other people who in the public who don't know, is talking about intrusive thoughts in a way that everybody has intrusive thoughts. You don't have to put them on the spot to tell me like what intrusive thoughts you've had, but everybody has them. But imagine having them and not being able to let go, and then doing behaviors to try to make them go away, but actually they just reinforce them and they keep going. And of course, you can tailor that to whoever's expertise. If you're talking to other people who understand neuroscience and using more of the circuitry to make it more legitimate. And if you're talking to people with, you know, psychiatric or psychological backgrounds, and talking more of the phenomenological, psychological symptom presentation, but, you know, distinguishing why it's not anxiety or an anxiety disorder, things like that. And then most importantly, to the vast people in the public, like, you don't need to get into all the detail of how it works in the brain, but just simply that illustrating that cycle and talking about how I also think it's important to say that OCD can latch on to absolutely anything. And so you can talk about anything people value. Obviously, these stereotyped, more known themes are less important to talk about because they know, but talk about everything else that it could possibly latch onto. And then talking about compulsions being anything, especially mental compulsions. Because again, most people, even if you are presenting with obsessional thoughts, most people, especially clinicians and providers, don't realize that behaviors can occur in the mind and they're not identified, nor do people who have OCD, when they don't have a diagnosis or understand it, they don't know how to verbalize oftentimes that, oh, I'm just constantly checking my memory, or I'm constantly ruminating over this, that, or the other thing. So anyway, my formula is tear down what it isn't, debunk what it isn't, why people think that, talk about how it relates to most people and how they exist today, and how people with OCD just happen to latch onto that and keep going, and how debilitating it can be. And I think that's where people with lived experience, or knowing people whose lived experience exists, you don't have to have it to talk powerfully about, this can cause people to be housebound, not be able to work, not be able to go to school, and really illustrating how devastating it can be to starkly contrast the quirk or the fact that it's a superpower. That was really long-winded, but you can make that shorter. And I found that to be really effective in my world, at least, especially when having to talk to so many different populations and dealing with the added stigma of people in positions of power, researchers, people like y'all, who have the ability to give me jobs and to legitimize my work, and seeing me as a patient. I have to really toe that line. And I'm speaking to anyone else like Kyle and other people who have to do this. Like, we have to constantly toe the line of, we are professionals. We deserve to be here. We do have lived experience. It doesn't make us less than, and our suffering still is valid, and both things can be true. So that's also a hard line to toe, especially when talking about taboo themes, which is also something people should be talking about and normalizing, as difficult as it is, because it makes other people more likely to be able to recognize it in themselves and say it without shame. I'll end my soapbox there.
Yeah, I think your point about that, intrusive thoughts are normalizing the experience. We all have intrusive thoughts, whether you have OCD or not, and we all do, compulsive rituals sometimes, extra checking, things like that. But they're, obviously for folks with OCD, this is just, it's a much more frequent, and it's more, frequency, intensity, duration. It's not a difference. It's not that these people have some sort of, disease. It is really on a continuum with what everyone experiences.
I agree with you. I think the caveat to that is sometimes when people who are listening to my explanation hear, oh, like I also have those thoughts sometimes, and once every few months I do get into a checking loop, and then they start thinking it's OCD. It sometimes, to emphasize the disorder part, means, at least by diagnostic standards, it takes up 1 hour at least. Like, that at least differentiates, like, some people might know what the experience is occasionally, and some people it ruins their life.
Yeah, I think that makes sense. Yeah.
I'm curious, Amita, you mentioned that you're running a study about like an educational program, maybe in schools, I believe. And Elyse, I know you do a lot of work kind of trying to spread evidence-based treatments. So like, what does the research say about the most effective ways to kind of get people in large swaths to recognize and accept what a category of a disorder might be, and then ways to get treatment?
Yeah, you're asking a huge question here. Yeah. How do we,
8 minutes.
Essentially, like, 8 minutes, not enough time, right? So there's places, institutions in place, and it's changing up the system. So how do we change up the system? How can we find champions within that system who get on board and who can really spearhead this?
What are those institutions in place that you're referring to?
Well, I just think about school systems, they have a way that they run things. How do we make sure that we can integrate this seamlessly into the system that they already have in place, right? So we're not just like, oh, I'm going to come here and I know what's best and listen to me and do this, right? We have to form those relationships. That's so, so important. Like, how can we understand, how the system works and how we can take our knowledge and integrate it seamlessly? Thinking about, we can use schools as an example. Teachers have so much on their plate. They do so much. So then also saying, okay, now you have to watch out for OCD in the students, that's super overwhelming for them. So how can we, provide more resources, lessen the burden? There's so many factors at play here. So that's I guess that's my in a nutshell. There's so many factors here.
Yeah, I would certainly agree. We did some research on this in increasing awareness of OCD in schools in the hope that they would increase detection, and I would completely, and it was positive for those schools. I mean, of course, it's a bit biased because the schools that kind of signed up to it would be interested in OCD. So it's again what you're saying there, Elyse, about that kind of broadening it, bringing it into the system. And we have managed to tap into that a little bit in the UK, at least, around they have some time where they think about well-being and mental health, and that's become more the sort of the norm rather than the exceptions in schools. And it's just trying to sort of embed that. And I think collaboration, co-production is really important. We worked with teachers and the school systems to develop that, and we have the lived experience voice throughout. So it's not just us professionals coming in. I don't know, I did that voice for a bit. I don't talk like that. But, you know, we always have somebody, and maybe a parent, a young person, whether they can be there in person with videos. And I think making it integrated, but also just low maintenance. So we've now developed kind of online resources where they can just click on, and it's less input for us and also for them. So completely agree. But once you're in and you can, you know, share the information, we've found from our research it does increase not only understanding and awareness of OCD, but we also did a follow-up of then are they picking up more young people with OCD? And, you know, it's a very small study, but the indicators were yes. So, which is positive.
Definitely.
I also wanted to add, especially in terms of what you were saying about co-production, that it is so incredibly important to include lived experience perspectives in whatever initiative you're making. And I'll give an example in a second. But I also think something that everybody from every stakeholder in the community, everybody on this panel right now as professionals, as well as people in the community, can do is tap into communities that are not the OCD community, which sounds so obvious, but whatever your vocation or stakeholder position is, for example, like I also research psychedelics. So I go to many psychedelic conferences and I'm talking about OCD in the context of psychedelics. Anybody who's a clinical psychologist going to generalized clinical psychology conferences or events and talking about OCD in that context. If you're someone in public health, like you're getting the idea here, like going outside of our bubble, which is really hard because we feel safe in our bubble and we're understood here in our work and our funding and all the things. Go outside your bubble. Talk about it to people who don't understand, and use language to make sense and get their attention. If I'm talking to a neurobiologist, use neuroscience. If you're talking to people with lived experience, talk about, you know, the pain and hurt of living. And I also wanted to shout out OCD in the Brain. It is an initiative that was co-produced by people at University College London that then extended to the IOCDF, people like me and Kyle and other people with lived experience and other researchers to create a science communication tool to distill down the neurobiology of OCD, what we think we know, because we don't know anything in science, as well as how research is conducted in a way that is completely understandable, but does not sacrifice any element of scientific integrity. And we can all do that with our work. We can all disseminate it in a way that's understandable and accessible. So please use that website. Spread that website to help raise awareness. And it also helps people realize this is a biological disorder and not just a choice or a quirk. So it helps with the stigma there too.
I want to share my screen before we run out of time. Actually, to that point, because I was doing some research, kind of looking around. Oh wow, I don't know if people can see. Here we go. At some of the literature on stigma, and I was kind of surprised to find that actually neuroscientific explanations of mental disorders don't help to reduce stigma. So in studies, neurobiological explanations were marginally associated with greater desire for social distance from people with mental health problems. In experimental studies, these explanations were associated with greater desire for social distance, greater perceived dangerousness, greater prognostic pessimism for the people who have these disorders. And, you know, we've heard for a long time, NIMH kind of had this, long-standing agenda of, let's make mental disorders biological, and that will get rid of stigma. Of course, stigma is worse than ever. And this is a meta-analysis of, they did like 26 studies where they looked at. So I'm not sure. How do I unshare my screen? I'm not sure that alone is interesting. I was surprised to find that, but I'm not sure that alone is the is the answer. I think we need to do more, kind of like Uma, what you were talking about before, to bring that real, this is an experience for someone, not just they have a brain disease, because that sounds like it can actually alienate folks.
Mm-hmm.
I think too, how do we have a shared language here? Uma, you made that point of what is our shared language? How do we appeal to the audiences that we're speaking to, and meet them where they're at? And really those lived experiences, I think, are so, so powerful.
Yeah.
Yeah, I also think it's kind of to Elyse, your point. Jon, that's an interesting study. I wouldn't have expected that. I'm glad you brought that up.
Very surprised to find that. Yeah.
But Elyse, you said finding a champion within an existing structure, and I think that's also super important, so that people can see someone at some position and say, oh, they have OCD, to this kind of point of trying to fight against stigma. It's not the end of the world. There's ways to get help, and there's ways to push through, and there's with OCD, you can live a full and productive life. And it's not something to be ashamed of, and it's not something to run away from or be scared of, because it's just something that, a person may deal with, but they can still live a happy and healthy life regardless. I want to give a shout out to the ICDF really quickly and just plug again that they're starting the research funding drive. I'm going to look at the little blurb I have. So this officially kicked off fundraising for the research grant program as part of the 30th anniversary celebration. So if you want to help fund research that we've discussed on the show and a bunch of other research that we've talked about for the last 4 years, me and Jon, please visit iocdf.org/donate research to learn more and donate what you can. We kind of ran out of time. I normally like to give people one last go round to say their final thoughts. But to be respectful of everyone's time, thank you all for joining in the chat. Thank you to all my panelists for joining. This was,
it's a lot.
I thought a super nice conversation.
Nice.
It was super great to hear so many diverse perspectives, and hopefully the six of us can move forward and do the good work of breaking down stigma and raising awareness of OCD.
It's great to talk about this among all of us, but right, exactly. We need to
got to expand a little bit now. All right, well, thank you all for joining.
Thanks, everybody.
Until next time.
Thank you.